Hi, good evening, everyone. Thank you very much for joining us tonight. I'm Dr. Ashraf Raslan, a rheumatologist here with the Valley Health System and Valley Medical Group. I've been working here with Valley since 2016, and I'm very happy to talk to today with you about osteoarthritis. It's an important topic that we want to talk about for a while now. It's important because it's very common and it does affect the function and daily life, quality of life and daily life activity for many people who has it. So let's talk about osteoarthritis now. See if I can move this. Okay, that's good. So I thought I'd start with this illustration of uh, the knee osteoarthritis. So if you look at the left-hand side, we have here a normal knee joint where you can see that the bones are in a good shape. The cartilage that you see in white is healthy and is covering the whole joint surface of the bone. Uh, we see the meniscus here. This is what's called the lateral and the medial meniscus, and these are part of the cartilage basically that helps keep the joint healthy. Now there is the joint space that is supposed to be it's basically a viscous thick material that is supposed to help keep the joint more flexible and also keep the separation between the bones. Uh, Works as a cushion as well, so it decreases pain with activity. Now, if we look at on your right hand side, we see here an osteoarthritic joint, and this is advanced osteoarthritis. So what we notice first is we see the cartilage here, it's worn off. So many parts of the bones are exposed right now, and the cartilage is basically worn off in many places. It's not as healthy. So it doesn't help produce this viscous material anymore that's supposed to keep the joint space there. So we lose the joint space. We have what we call joint space narrowing. So the bones become closer to each other. Obviously, the bones are exposed, so they're going to get irritated. We have this new bone formation that we call osteophyte. And this usually would lead to it leads to pain. Also, it leads to some change in the shape of the joint, what we call joint deformities, or hypertrophic, like meaning the joints looks bigger, and this can happen in the knees or the hand joints. And this is obviously can lead to pain as well. This is how we would see it on the X-ray. So this is a normal knee. On your left-hand side, we see the bones look in a good shape. We can see the shadow of the cartilage, which looks good. And there is a good joint space, healthy joint space between the bones. Now, if we look at the right-hand side, we see knee osteoarthritis. It's mainly here, it's in the inner knee is involved here, which is a very common place also to have osteoarthritis, the inner side of the knee here. So the bones are too close to each other, the cartilage is worn off, and we have here some extra bone formation, what we call osteophytes. This is osteoarthritis in the hand. So the same process that we talked about in the knee, it would also affect the hand joints. So we have here what we call the nodes. These are called Heberden nodes. So we have the nodes that basically consist of new bone formation because of the osteoarthritis in these joints, and it's a very similar process to what we talked about in the knee. So as we say, this is an important topic because it's very common. About 52 million people in the US are estimated to have osteoarthritis. A very large percentage of people over 50-year-old have osteoarthritis. It is one of the main reasons for disability and for loss of like quality of life and ability to ambulate here in the US. It does affect many joints, hands, hips, knees, feet, and spine. You can see here um, the knees and hips and hands are maybe the most affected, the lumbar spine as well, and the neck joint and the first joint. Same thing here. We see basically the most common joints. I would say that we see the most are the knees, the thumb bases, the base of the thumb, the neck and the lumbar spine, and the big toe. Other joints could be affected, less likely to affect the shoulder, but it could affect also the shoulder, uncommonly in the ankle and wrist. But what exactly is osteoarthritis? So osteoarthritis in the past, it was considered to be only a simple wear and tear. So the idea was that we use our joints all our lives, and at some point from the chronic wear and tear on the joint, the cartilage wears off and there is damage to the joint, and it's just a simple wear and tear. But now we understand that it's a much more complex process than that. We understand that there is some chronic inflammation that actually plays a big role in the development of the osteoarthritis and the loss of the cartilage and the other structures in the joint. There are what we call biomechanical factors. So some factors that make some people more susceptible to have osteoarthritis. It's usually involves the alignment of the joint, the length of the lower extremities. There are other factors like muscle weakness or problem with the tendons. All of these can contribute to the development of osteoarthritis. And we know also that genes play a role, and some people genetically are more predisposed to having osteoarthritis than others. So talking about that, we'll talk about the risk factors of osteoarthritis, right? So obviously age, as we said, it's not a simple wear and tear, but osteoarthritis is more common after 40 and especially after 50 for many reasons. One of them is wear and tear, but it's not the main reason. Another is like as we get older, there is more inflammation in the body, and this inflammation can lead to more joint deterioration. Also, the health of the cartilage becomes the cartilage is not as flexible or not as resilient as we get older. So the health of the cartilage is not as healthy. It doesn't. It's more susceptible to injuries. So we get more injuries usually after the age of 50 or so, and so there is more incidence of osteoarthritis. Joint injuries. So, for example, athletes who get like an ACL tear are more prone to have a knee osteoarthritis in the future. Obesity is one maybe of the most important factors because obesity is potentially a modifiable factor, and it causes osteoarthritis in two ways. One is the abnormal physical load on the hip and knee joint, and this can lead to more stress on the joint, on the cartilage, on the ligaments, and more joint injuries. So it can lead to more osteoarthritis. But the other way it leads to arthritis is also by causing inflammation, because fat cells produce inflammation mediators that can cause damage to the cartilage and damage to the joint structure, and this can lead to osteoarthritis. And for example, like in people who have obesity, they not only have more hip and knee osteoarthritis, but they also tend to have more hand osteoarthritis and shoulder arthritis and shoulder rotator cuff problems. And obviously the hand osteoarthritis is not related to increased physical load, but rather to chronic inflammation from the inflammation mediators that are produced by the fat cells. So that's an important factor that we always keep in mind and try to modify. As we say, genetics play a role, and there are some genes that actually can predispose to early osteoarthritis. Anatomical factors, we talk about that when we talked about the mechanical factors, which mainly people who have, let's say, both legs, or they have difference in the length of both lower extremities, or scoliosis. All of these can put more pressure on one joint compared to the other, or one side of the joint compared to the other side of the joint. And this can lead to more joint injury and wear and tear over time. Sex plays a role as well. We see osteoarthritis more commonly in women after the age of 50. We think it could be due to hormonal changes because of the loss of the estrogen protection, protective effect on the cartilage. And another thing that is very important to keep in mind is diet. So yeah, we get asked a lot about diet, and there is no diet for arthritis, and there is no diet usually for like inflammation in general, but usually eating a more simple, healthy, balanced diet is usually what is proven to kind of help decrease the progression of osteoarthritis and decrease the incidence of osteoarthritis. So, for example, things to avoid are things that are like highly processed, fast food, frozen food, foods that are very high in like sugar content or very high in animal protein. All of these things can promote more inflammation in the body that can lead to more joint damage. Maybe also including more simple ingredients and more ingredients that have omega-3 that can decrease inflammation, like nuts and seeds and fish can help decrease the progression or prevent osteoarthritis. So many risk factors, as we said. And now we talk about the symptoms. So something to keep in mind, though, that not everyone with osteoarthritis has pain. And it's important to keep in mind because many times people get alarmed by basically for some reason, they get an X-ray or a CAT scan of the back or a joint or so, and it does show a lot of osteoarthritis, a lot of wear and tear in the joint, although they don't have much pain in that area, and it's not really concerning. So if you do imaging for everyone over 50, everyone will have some osteoarthritis, and it's not always painful. And the reason is we think the pain in osteoarthritis is produced by many factors. It's not only the simple load on the bone is exposed and there is more, and when you put weight on the bone, when you load the joint, it's going to hurt. That's not as simple as that. There are many other factors that play a role in the pain in osteoarthritis. It includes the health of the soft tissues around the bone, around the joints as well, like the tendons and the ligaments and the muscles that are carrying it, the strength of the muscles, the nervous system, and for example, some people could have severe osteoarthritis in the knee, but they really don't feel any pain. They're able to function fine. And some people could have only mild to moderate osteoarthritis, but with severe pain. And we think this is also because of the difference between different individuals in the function of the nervous system. How does it transmit the pain signal between the joint and the spine and the brain, and their ability to inhibit this signal when it's not needed. So in some people, this signal of pain is not inhibited, and this leads to this chronic severe pain that sometimes could be related to the central nervous system, what we call central sensitization, meaning that it's really not because of the joint damage mainly, but just because of the nervous system producing this signal of pain all the time and not being inhibited. So, but the symptoms, obviously, the main symptoms are pain and stiffness. This is usually it has some characteristic kind of like findings that we see, like the pain is usually worse with activity. So it's, for example, hip and knee pain is many people, it's hard to stand from sitting. When you stand from sitting, you have the pain. After walking for a while, there's more pain. Stairs are very difficult typically. Same thing with like lumbar spine osteoarthritis or spinal stenosis, which is a type of osteoarthritis in the spine. Walking is very difficult usually. For hand osteoarthritis, especially for the thumb-based osteoarthritis, usually certain movements that require a strong grip are difficult, especially also like twisting movements like opening a jar or opening a doorknob can become difficult usually. So there is like some specific pain and stiffness symptoms of osteoarthritis that are different from other kind of arthritis usually. This can lead to muscle weakness, mainly because of the loss of use of the joint. We use the joint less and the muscles around the joint get weaker. It's very typical for, let's say, knee osteoarthritis to have weak quadriceps muscles. The quads become weaker. Same thing can happen with spinal stenosis, lumbar spine osteoarthritis can have a weakness in the core muscles. And this can lead to impaired balance, which is a problem in many people with knee osteoarthritis. The balance mainly happens because of the muscle weakness. Sometimes also the joint is not very stable if there is advanced osteoarthritis. So how do we diagnose it? I think, as we said, there are some typical features or like symptoms of osteoarthritis that will make it easier to diagnose. So the characteristic symptoms of having pain with activity, pain with using the joint that improves with rest. This is a typical symptoms of osteoarthritis. There is mild pain and stiffness in the morning, but this shouldn't last for a long time. Usually, unless the osteoarthritis is advanced, it doesn't usually affect sleep. And on exam, there are certain exam findings that are typical for osteoarthritis. So if you look here, we have on your right-hand side here, we have osteoarthritis is the picture we saw before. So this is a typical finding for osteoarthritis in the hand, where these are kind of bony enlargement that are solid, and there is no fluid, there is no actual swelling, there is no warmth in the joint. So this is typical for osteoarthritis. But if we see this hand on the left-hand side, this is rheumatoid arthritis, and it's different. The joints are usually inflamed, so there is more fluids inside the joints. The joints could be warm, could be what you call squishy to the touch, and they're very tender usually. Another thing to keep in mind also that rheumatoid arthritis and osteoarthritis, they affect different joints. So rheumatoid arthritis typically affects these knuckles here and maybe what we call the proximal joints in the middle of the fingers, but it does spare in most people these distal joints. It's the opposite on osteoarthritis. The distal joints here, the end of the fingers, are the most affected, and usually these knuckles are usually spared. They are affected in rare cases. But if the symptoms are not clear, or if we need to assess the severity of the osteoarthritis, then imaging is a great usually way of looking at the joint. X-ray is what we start with. In some cases, we get an MRI for better evaluation. So we see here, this is the normal knee joint that we looked at before, and this is how osteoarthritis would look in a knee joint. Same thing, this is how osteoarthritis would look in the hand. So again, most commonly at the end of the fingers, we see here the destruction of the joint space, and with the extra bone formation because of this reaction of the bones to the basically loss of the cartilage and the loss of the joint space. And so this is what usually we can see on exam, can feel on exam. And this is like a comparison between, let's say, this is osteoarthritis, and you see how these joints are affected. And rheumatoid arthritis, where they affect different joints. The knuckles here are affected and have a lot of arthritis in them. And also, there are certain changes in the bones that we see in rheumatoid arthritis, like what we see here, if you can see it, what we call erosions, like some of the bone is eating up by inflammation that we do not usually see in osteoarthritis. So X-rays are very helpful, but some instances we need a better image like an MRI to be able to see the soft tissues, like the meniscus in the knee or the tendons and the ligaments, to get a full picture of what's going on. So symptoms, and if we need x-rays, these are usually, and the exam, these are usually how we diagnose it. We don't need any blood work, so labs are not really part of diagnosing osteoarthritis. We get labs sometimes to rule out other things. If someone has joint pain and maybe some swelling, joint stiffness that is not clear, and maybe there are features of osteoarthritis, but also features of inflammation, we get blood work to rule out other forms of arthritis, like rheumatoid arthritis or psoriatic arthritis. So this would be the only reason to get blood work. Otherwise, there is no specific blood work that would show us osteoarthritis. And I think most important, we have to talk about the management. Right? So how do we manage osteoarthritis? Now, unfortunately, we still do not have any way of reversing the process of osteoarthritis. Like ideally, the best treatment would be, and the treatment that I think is being also researched more and more these days, is how to maybe try to regenerate the cartilage and create a healthy cartilage again that can protect the joint and support the joint and again improve the joint space again. So we're not there yet, and there are kind of a lot of research about that, but unfortunately we don't have that yet. So now our goal is to try to minimize pain and optimize function, and try to modify the process of joint damage, and maybe try to stop it if possible, as much as possible. And so there are like three things that we talk about usually in treatment, what we call non-pharmacologic, so conservative measures and exercise, and so pharmacologic, using medications, and surgery as usually as a last option for treatment. So if we talk about non-pharmacologic interventions, I think the first thing that comes to mind is exercise. Now, exercise is very important. Now, it's very difficult to do. Have osteoarthritis, knees hurting, other joints like osteoarthritis of the lumbar spine, spinal stenosis. It's difficult to exercise, it's painful to exercise, but it is very important. It's one of the things that exercise actually is studied very well, and it's proven to decrease pain compared to other pain medications that we use for osteoarthritis, if it's done on a regular basis and done for a long enough time. So exercise is important, and we do it usually either like by a combination of physical therapy, which is important to maybe start the exercise program and learn what kind of exercises are the appropriate ones to do and the right way to do them, and home exercise, obviously. And exercise, it's very different. It's very individualized between different like people. It depends on like what are the goals and what's the ability to do exercise, and obviously also what are the joints that are involved. But it is an important part of our treatment. When the muscles are stronger, let's say we have a stronger thigh muscles or quads, this would actually improve the space of the knee joint. It will decrease the load in the knee joint, and this will help improve, both decrease pain and improve function. So exercise is very important. Many different kinds of exercises, land exercise or water exercises. So that's something that we always focus on. And the other thing that obviously will also be important is weight management. Important, not easy to achieve, especially if someone has knee osteoarthritis, hip osteoarthritis, spinal stenosis. The activity is a little bit limited, and cardiac exercise is or aerobic exercises are not easy to do. It's a goal that we try to achieve. Not always easy, but it's very important to focus on. And it's good to have a goal. Good to set a goal usually of like how much weight do we want to use. And what is studied, and it's clear to help, is a weight loss of about 5 to 10% of the total body weight is going to give a good amount of relief. So let's say if someone weighs 250 pounds and we aim for a 10% weight loss over the next 6 months to 1 year, so we need to lose about 25 pounds. So this is actually proven to help after a year or a year and a half, to help about like decreasing the pain of about 50%. So it's really significant decrease. of the pain with a 10% weight loss. But it doesn't, usually the improvement is not realized quickly, is realized usually after 6 months or a year or more. So that's why it's something that we need to set a goal and have patience. And usually it does help for the long term. And another thing that we do use are braces. Now, if you see here, we have, this is like a symbol, what we call a sleeve brace. And this is good for people who have mild osteoarthritis who are active, because this one can decrease some of the load on the joint and so can allow to do more activity without putting too much pressure on the joint. And it should not be worn all the time, but worn during activity during the day for a few hours. That would be a good way to use it. For people who have more advanced osteoarthritis, and especially if they have more osteoarthritis in one part of the joint, there are more advanced braces that are called unloaders. They kind of unload the weight from the joint, and they could be adjusted. So these are also good for certain people with osteoarthritis, a good help. We use for thumb-based osteoarthritis, the basal joint here. We use this thumb and wrist brace, which is also very effective usually in decreasing the pain in some people by basically preventing the overuse of the thumb joint. So all of these are important, especially exercise and weight management are very important ways of managing osteoarthritis, and they should be the first things that are done for that. Now, many people do require some pharmacological therapy, medications to help with that. And the rule with medications always is we want to use start with the medications that has good efficacy but the least amount of side effects. And that's why usually our first recommendation is topical treatment, because this has less side effects usually than systemic treatments. So what we call NSAIDs, non-steroidal anti-inflammatory drugs, NSAIDs. So the topical NSAIDs or topical non-steroidals are the first line usually for people who have 1 or 2 or 3 joints only affected, especially as we talk about the hand or the knee. It works usually well for these joints. Not for everyone, but for many people. You might know it, it's called Voltaren gel or diclofenac gel, and this is usually applied between 1 to 4 times a day. It is much safer than taking oral medications because the systemic absorption is about 10% or 15% of what we see with the oral treatment. So these are good options that we can always start with. Now, if needed, if this doesn't help enough, the oral non-steroidal medication, oral NSAIDs, are effective in many people. They're over-the-counter like Aleve or Advil or ibuprofen, or prescription medications like Mobic and Celebrex. They're effective, they work well usually. They have more side effects. And there are certain, like in certain people, you cannot use them. If someone has a history of a stomach ulcer or a history of kidney disease, we usually prefer not to use them, although we could, but maybe with caution. They can cause side effects, especially related to stomach pain or sometimes diarrhea, elevated blood pressure. So they need to be used with caution, but overall, if they're used right and used with maybe the minimal effective dose, they're usually very well tolerated and they work well. So these are maybe the most commonly used treatments for osteoarthritis. Now, for people who have contraindications or they cannot use the oral anti-inflammatories, then duloxetine or Cymbalta is actually a good option. It is an antidepressant, but it's used more for actually pain management more than depression these days. And it is a good effective medication especially for people who have knee osteoarthritis or sometimes lumbar spine osteoarthritis. So it definitely could be used. And remember, this is like, it's an antidepressant, it decreases nerve pain. But when we talked about what causes the pain in osteoarthritis, we said it's many factors. And obviously, one of it is maybe some inflammation, local inflammation because of the irritation of the bone, but also some of it is this chronic nerve overstimulation because of the osteoarthritis and the fact that the signal is not being, the pain signal is not being inhibited. And so medications like duloxetine, that's how they work, by modifying this pain signal. There's what we call topical capsaicin cream. It actually works. It's very safe. It can work. It's not as effective as the others, but it's worth trying. Some people, when they start it, they can have burning or a sensation, a hot sensation. The skin becomes really irritated. That's very uncomfortable. But if it's not too bad, it's worth trying for a few days, because usually these side effects do subside over time. And if we have certain joints that are more inflamed, like the right knee is really painful, if you have like the thumb base joint is very painful, affecting activity, and the other interventions are not really helping enough, then doing cortisone injections only as needed is something that's effective. It does help. Cortisone injections can help anywhere between 4 weeks to 3 or 4 months, sometimes longer. Sometimes the joint pain doesn't come before. If they're done only as needed and not on a regular basis, they're usually safe and effective. We like to avoid them if possible, because there are, especially like if they're done frequently or overdone, there is always a risk of worsening osteoarthritis because of the steroid in the joint. So we try to avoid that. And the other thing, also, it's an injection, so there is always a small risk of bleeding or infection when you introduce a needle to the joint. So, but they are effective, especially for certain joints like the knee, the hip, or the hand joints. Now, the other thing that is very commonly used is what we call hyaluronic acid injection. And these are gel injections, or some people know them as a roster comp injection. So what are the hyaluronic acid or the gel? It is a thick material, thick collagenous material that is very similar to the viscous thick material that we have naturally in the joint space, and is lost when you have osteoarthritis. And so this injection is, the idea of it is to give this temporary thick material in between the bones to give some cushion to the joint. And it could also some studies show that it can decrease inflammation, maybe, or like the activity of the inflammation mediators. It does not work for everyone, and there are many studies about it. It didn't show great efficacy, but it does work well for some people, and it is also worth trying because minimal side effects, and usually it's considered very safe. And it doesn't work for everyone, and there is a possibility that it does not work for everyone because, as we said, the mechanism of pain, or like the reason for pain in osteoarthritis, could actually be different between many different people. And maybe if the reason of pain is mainly the joint space narrowing and the irritation of the bone, this would work. But if the reason of the pain is nerve overstimulation and non-inhibition of nerve signals, obviously this would not work. So that's why they don't work for everyone, but they are definitely worth trying if other modalities do not work. And supplements, not much there. There are the studies show that mostly curcumin or turmeric are actually the ones that are studied and show maybe to decrease inflammation and pain of osteoarthritis. And the dose usually is about 1,000 milligrams a day. That would be a good dose to take of turmeric. It's better to take the combination of turmeric and black pepper because that's usually better absorbed by the stomach. Otherwise, it is hard to absorb and it might not work like that. Fish oil can decrease inflammation in the body. It's not really proven to help osteoarthritis, but it is definitely worth taking. It might help with decreasing the incidence of arthritis. Vitamin D, again, controversial, doesn't harm. Maybe it's a good supplement, but we don't know how much does it work. But it is something that also could be tried, especially if there is vitamin D deficiency. Now, these are the main treatments, the main pharmacological therapies that we use. Now, you might notice that I didn't mention Tylenol or acetaminophen, and that's mainly because Tylenol is actually not recommended anymore because it's not really very effective. Now, look, if it works for you, that's good. It's a safe medication overall, and if it works, we could still use it. It's not recommended because studies show that it doesn't really work much more than placebo, and it's not worth the risk of some side effects. It still could cause some really kidney problems or liver problems, and some people tend to overdose on it because it's not really as effective, so people tend to take more of it, and that's why it's not recommended anymore as a first-line treatment, Tylenol. But if it works, it's also a good option to take. The other thing I didn't mention is some of the therapies that are not studied, including plasma, rich platelets, PRP injections, or stem cell injections. These are done. Some people see improvement from them, but there is really no study to support them. And there are studies, but they don't show that they work. And that's why we don't use them. We don't really recommend them. The studies that were done on them, they showed that really there is no difference between what we call a placebo injection and these injections. They don't seem to be harmful though, but again, there is no, at this point, they're not recommended because they're not really studied well. And, other than pharmacological therapy now, the last option, if there is really severe osteoarthritis or osteoarthritis that's affecting the function or causing a lot of pain and discomfort, now surgery is usually the next option. And mostly, especially if we're talking about the knee joint and the hip joint, this is usually a total joint replacement. That's the most common surgery. Now, in certain instances, in the knee, you could have a partial joint replacement or the hip. And this usually if we have osteoarthritis in only one part of the knee, but the rest of the knee joint is intact and the ligaments look in a good shape. So you could have a partial joint replacement, which is, it has specific indications. And if someone needs a joint replacement, this definitely could be discussed. The good thing about it that the partial joint replacement, the recovery is much easier, the outcomes are better usually, and it could be converted to total joint replacement in the future, usually, if needed. And there are other surgical interventions for osteoarthritis. Let's say for like hand osteoarthritis, there is sometimes replacement of the thumb basal joints or fusion of some of the finger joints if needed, if they're causing a lot of pain. In the case of lumbar spine osteoarthritis and spinal stenosis, also like lumbar fusion is another surgical intervention. And again, surgery should be left as a last resort. Would always try with non-pharmacological and some of the safe pharmacological options first, and try to modify all the risk factors of osteoarthritis before considering surgery. And yeah, I think that's it. Thank you very much for listening. I'm happy to take any questions.
Thank you so much, Doctor. It was so interesting and very thorough. Just a few questions, if that's okay.
Of course.
Somebody had questions about does do you know anything about eating nightshades affecting osteoarthritis, if that's been something you've heard?
Yeah, there is a lot of talk about nightshades and osteoarthritis, but there is all the studies show that really nightshades like eggplants or I think tomatoes and potatoes and so on, they don't really cause inflammation or affect osteoarthritis. So that's okay to eat. Like for example, if we talk about the main study that looked at the development of osteoarthritis over time, it did compare the Mediterranean diet to the regular Western diet. And it showed that people who were on a Mediterranean diet for a long time, like it was what we call a crowd study. So like thousands of people were followed for like 20 years or so. The incidence of osteoarthritis and the severity of osteoarthritis was much less in Mediterranean diet. Now, Mediterranean diet is actually usually rich in nightshades like tomatoes and eggplants. And so the idea is like you don't really have to avoid any of these because there is no evidence that they cause inflammation. If you eat a simple diet that or a diet that's balanced and have simple foods, whether it's nightshades or even if it has dairy or gluten, as long as it's like balanced and has more simple foods than processed foods, this should actually cause less inflammation and help decrease the incidence of osteoarthritis.
Okay, thank you. And just you mentioned turmeric and what it should be combined with. Do you know
turmeric usually? So turmeric or curcumin. Curcumin is the substance that's effective in turmeric. We cannot really absorb it. So to be absorbed, usually when you buy it from the pharmacy, it's usually combined with black pepper.
Okay.
Yeah.
And does arthritis often develop in one hip and not the other? Does that happen, or is it pretty much?
Yes, it could. So in most instances, it is in both hips or both knees, but it is usually more severe one side than the other in most people. And that's again related to previous joint injuries, related to which side is more dominant, so which side carries more load usually, and sometimes related to maybe like a difference in the length of both legs, so one hip or one knee is getting more brushing than the other side.
And somebody asked about osteoarthritis in the hands, and does weight impact that as well, would you say?
So yes, so weight impact that not directly by weight, by load, but by causing inflammation. So when there is extra weight, the fat cells produce inflammation, and these inflammation mediators can actually cause more osteoarthritis in the hands.
Somebody was asking about and it's really just one question together, like can gel injections be helpful if the knee has progressed to bone on bone, or like when should you consider knee replacement at that?
Yes, yeah, that's actually a very good question. And knee replacement, so gel injections could be tried even if the knee is close to bone and bone. It still could help sometimes in improving the flexibility of the knee joint. And again, it's not effective in everyone, but it's worth try as another way of treating the knee osteoarthritis if the other interventions didn't help. Now, regarding joint replacement or knee replacement, it should be only considered if the pain is affecting the function, so affecting the daily function, the daily walking, or if it's leading to muscle weakness. What I mean, like we don't usually look at the amount of arthritis in the joint to decide if someone needs replacement or not. We look at their function. So whether the arthritis is moderate or severe on X-rays is really irrelevant. What's relevant is usually how much pain do they have, how much they can do. And if there is a significant decrease in the function and the quality of life, that definitely would be a reason to do a knee replacement. But again, it's always worth work first in the other interventions, like try exercise for 6 months to 1 year, and maybe a weight loss as you said, like a goal of maybe losing about 10% of weight over 1 year. along with the other interventions that can help with the pain or the medications. And yes, if these don't work and the arthritis is affecting the quality of life, then definitely knee replacement would be a good option.
Okay, and question about Voltaren. It sounds like it's recommended not to be used more than 21 days consecutively.
No, that's actually not. Yeah, that's not accurate. I think these recommendations. It's a topical treatment, but these recommendations sometimes the prescription wouldn't differentiate if it's topical or systemic treatment. But for the topical therapy of Voltaren or diclofenac, it is actually safe to be continued long term. If it's used only on like a few joints, like let's say some of the hand joints and the knee joint, that's safe to continue long term.
Even like over the course of a year, even would be okay.
Exactly, even over the course of a year or several years.
Great. And let's see, I'm gonna go down another. Oh boy, I'm in trouble here. Okay. Are there any negative side effects of the cortisone shot in the knee, or too many shots, or?
So the side effects are rare, but yes, there are some negative side effects. So anytime you put a needle into a joint, there's a very small risk of causing an infection or bleeding in the joint. These are rare, and never seen it actually here, but it's something that theoretically could happen. So this is one of the side effects to consider, but it is rare. Now, if the steroid injections are repeated frequently, there is evidence that they could make the osteoarthritis worse. They might accelerate the progression of osteoarthritis. And that's why usually we try to do them only when needed. And if they done only as needed and infrequently, they're usually very safe. But yes, they definitely could, let's say, worsen osteoarthritis if they're done more than should. Rarely it can, even one injection in the knee, let's say, can make the osteoarthritis worse, but that's rare.
Okay. Also a question about, do you know any patients have varicose veins and on knees, and if a knee brace may be problematic, is there any alternatives that you would suggest?
Yeah, so knee braces definitely can, if there is like swelling in the legs and the lower legs, if there are varicose veins, these would be hard to use for sure. There is no, for loading, there is really no good alternative bracing wise.
Okay, thank you. We have a lot of questions, folks. We'll do the best we can. If you have joint pain, maybe from a different illness, like Sjogren's, am I saying that right?
Sjogren's, yes.
Okay. Is that also relative to osteoarthritis? Is it similar?
If someone has Sjogren's?
Yes. Is that a type of arthritis with the same?
Yes. No. Sjogren's is an autoimmune disease that people with Sjogren's could develop joint pain and some arthritis in the joints, but it usually is not severe enough to cause damage to the joints. So no, we don't usually see more osteoarthritis in people who have Sjogren's.
Okay. And you had mentioned, I think you had mentioned the name of a medication injection that's given only about every 6 months.
Yes, so these are what we call the gel injections.
Gel, okay.
Yeah. So the official name or scientific name is hyaluronic acid, and these are this acid is the same material that is usually present in normal joints, in our joints, in the knee joint or so. And when we have osteoarthritis, we lose this viscous material. So there are these gel injections that we could inject every 6 months, and they do work for about 50% of people. They do give a cushion to the joint that usually would last for about 3 to 6 months.
Okay. Let's see. Also, do you are stem cell injections effective at all? Do you know anything about them?
So, I mentioned, I think at the end, that's why I didn't talk about stem cell injections or plasma-rich platelet injection, because these are not really studied. The studies show that they're not really effective. But there are no large studies about them. And so far, all the studies that we have show that they really don't do anything. So it's more of a theoretical principle that if you inject a stem cell, it will regenerate cartilage, but it just scientifically doesn't make much sense. And so it, from our experience, it doesn't do anything. It doesn't do any harm, but doesn't do any good.
Okay. People have a lot of questions about osteobiflex, glucosamine, chondroitin. I mean, I think
Yes.
you kind of alluded to this, but what do you think of those?
Yeah, it's hard. It's these, again, we usually depend on like the large studies that were done to kind of determine. So, for example, how they do the studies, they usually look at like they bring like several thousands people. They give half of them glucosamine, and the other half they give them placebo, like basically an empty pill. And they follow for like usually 6 months to 1 year, 2 years, and see if there is any change. And so far, all the studies that were done on glucosamine or chondroitin or Biflex or all of these kind of commercially available supplements, it really didn't show any effect. Now, for me, if they're not harmful as well, they didn't show any side effects either. And so for me, if someone is taking them and they feel that they're helping, I'm actually okay with that, because again, they're not harmful, and because osteoarthritis is very complex and the pain pathways are very different between different people, it is possible that maybe it could help some people, but we do not have any proof of that. So I wouldn't, if I have osteoarthritis, I wouldn't start it. I wouldn't recommend it to my patients. But if someone tries it and they see that there is good improvement, there is also no harm of continuing it. So that it's okay to use, there is no good evidence behind it.
Thank you. And somebody asked about, forgive us if you already mentioned this, but how long can you safely take Mobic?
So Mobic is what we call an unsteroidal or an NSAID. It's very similar to Aleve or Advil or ibuprofen. We say like it's better to use the minimal dose that works for the shortest period of time. So if it's possible to use only as needed on days that maybe on bad days that someone has a flare, or in days maybe that someone wants to be active, like someone with knee or a back arthritis playing golf 3 times a week, and they want to basically on the days that play golf take Mobic. So that would be a good way sometimes to take it only as needed. Now, some people with bad osteoarthritis, they use it for years or for life, and if needed, that's also okay. But just to remember always, like, the more you use it, the longer you use it, the more risk there is of like some side effects, like increase in blood pressure or kidney injury or stomach problems, stomach ulcer, that can happen with these medications. So it's always best to try to use the least amount possible for the shortest duration. But if it is needed long term to control the pain, that's something that could be used and relatively safe.
And along the same line, well, someone asked about cortisone shots and sort of how many or too many, how often safely.
I would say the maximum you could do, or like the most frequent you could do, is every 3 months. Better to be done less than that. So let's see, if we're doing a cortisone shot in the knee, we could do a cortisone shot every 3 months on a regular basis, so 4 times a year. But that's the maximum, but it's better to be done even less. So usually we try to space it to every 6 months if possible, or once a year if some people have relief for that long. If again, like, depends, but if it's really needed, then it's every 3 months.
And we're going to do one more. It's interesting question about noise coming from the knee. I have arthritis and a torn meniscus. What would the noise be? Would you know?
Yes. So the noise is many times actually it's a mechanical noise. So when some people with normal knee structure and without any osteoarthritis, they still have some cracking noise that comes usually from the movement of the ligaments and the tendons over the bones, and this can in some people reduce this noise and movement, which is normal. Now, with knee osteoarthritis, there is more creaky noise sometimes that happens. Some mechanical noise happens from the actual kind of like movement of the bones against each other. Or, as we said, there is extra bone formation because the bones get irritated and there are these extra bones that form on the side of the joints. And when the tendons and ligaments move over them, they kind of form this creaky sound that we hear when the knee moves.
Interesting.
But it's not a bad sign. It could be annoying though.
Just said something. Okay, one last question. This is it. And can you use gel shots for shoulder arthritis?
No. So gel shots are mainly used for knee arthritis. They're not recommended, but maybe could be used for hip, but not for the shoulder. The shoulder joint, you need the knee arthritis is a one joint space that is easy for the gel to stay in. The shoulder is a more complex joint that there is really no good space to inject the gel in, and it wouldn't really stay there. So no, we don't usually use it for the shoulder or the hand.
Well, thank you so much. Few people said thank you. It was such an